Hello, this is Dr. Bhomik. Those who are following my YouTube lecture, by now you know that who I am. So I'm ex-professor of pediatrics and chief of the division of pediatric endocrinology, University of South Alabama College of Medicine, Children and Women Hospital. I'm also a retired colonel from U.S. Air Force Medical Corps. As you have seen the title, today I'm going to do a little bit different subject. Childhood obesity, detection and management of early complication. Now, this is not an endocrine subject. Then allow me to introduce myself in this respect, why I am interested in that area. Beside being the chief of endocrine, for 5 years I was director of childhood weight management of children for 5 years. And our team included another pediatrician, one nurse practitioner, exercise physiologist, and two nutritionists. And over the period of 5 years, I learned a lot, and we did some research in that area also. And like others that everybody knows, I realized that this is a really humongous problem. This is not only the problem for pediatrician, it's a problem for internal medicine as well, because the obesity, if not taken care when they are young, and they will carry on to the adulthood, and that will be the source of many diseases and morbidity and mortality. So with that, let me tell you that the prevalence of obesity is rising in an alarming rate in children, adolescent. Well, this is not only a problem with the Western country, and many developing countries who are following our type of food habit are also facing this problem right now. And in this country, in the United States, it has been said clearly that the children from the racial minority group and those who have poor economic status suffers disproportionately, because it is easy to buy high carbohydrate containing food than getting vegetable and meat, which is more costly. It's a major public health problem, and if we do not address this one very, very seriously, then we are going to lose a generation. An effect of obesity in general and mental health is also far-reaching. What I mean is this: psychologically, the children, those who are obese, are significantly disturbed as well. So this is a little picture that I took from one of the obesity magazine, and this picture has had an underlying quotation, and what it said is, this is a cute little boy. He has got little chubby cheek and looks really nice, but this is the beginning of the problem. This is the beginning of the obesity, and it should be addressed from here. Now, the available statistics that Tamra and her colleague that published in Pediatrics. And I have also gone through some of the recent statistics, and there has been no changes, significant changes. So therefore, I use their data. It suggests that between age 2 to 5 years, if it is a Caucasian child, the percentage of obesity is 8.2%. If it happens to be a Hispanic, then it goes up to 13.1%. And African American is also not much difference from 2 to 5 is 8.8%. However, look here. As they approach, become older and older, and then you can see in Caucasian people, the rate is 12.7%. The Hispanic almost double, 23.4%. But right here, looks like African American is kind of taking over 3.8%. These numbers are not as much important as it says. The problem is there, a very significant problem, whether they are 13, 23% or 25%, it really doesn't make any difference, but you see that this pattern is alarming. So with this data, so let's look at this risk rate of the patient and their parents, and if they are overweight, and how do they fare. Let's see. If the both parents are of normal weight, has got normal body mass index, the risk of the child to develop more obesity or overweight problem is about 7%. However, if you look at that, one parent is overweight, it jumps to 40%. And this is shown in African American, Hispanic, Asian American as well. If both parents are overweight, then it goes 80 to 90%. So clearly, in our clinic, we found that our success rate was significantly low when both parents are overweight. And not only that, some of the parents even did not believe that they are overweight. And so that when you see confronted with that kind of situation, you'll know that you are actually fighting a uphill battle. So this statistic can give you an idea that what the enormity of the problem. So why should we concern that much about the obesity? And as we say, and this is the motto of World Health Organization, prevention is better than cure. And those who have dealt with obesity clinic or overweight clinic know that how difficult it is to convince or get a very good result. It does happen almost like a few and far between, not as many as you would like to see. And so these most cases are very difficult. The cure in most cases are very difficult, if not impossible, but it is doable. There are lots of effort should be done and should be put in that area. So let's see that what was the implication, what is the ramification of obesity in childhood. Now, we now know the atherosclerosis starts from childhood. Now, in the Vietnam War, in mid-60s, the two Army Surgeon Anderson and McNamara actually opened our eyes. And how was that? They did autopsy on American soldier and the Vietnamese soldier who were fighting with American. And when they died at the age of 18, 19, 20 and so forth, and they found the American soldiers, the atherosclerotic changes or the lipid deposition in the intima and media is almost 3 times more than same as Vietnamese soldier. So from that point we know that this is not something they start when they like a 30, 40 or 50. So therefore, I think this statement that I have heard from my adult colleague, cardiologist, they say that a person who gets a heart attack or myocardial infarction or heart attack by the time they are mid-40, harboring this atherosclerotic condition from much earlier age, from 8, 9, 10 and so forth. So problem should be addressed right there. You don't wait until you are 40 and already have problem. And that's why the lipid screening and the other thing has also been implemented in a pediatric age group, and which itself is a very different topic. And there is a saying, it is not what you weigh, it's where you weigh. So it's the visceral obesity which is more dangerous. But I'm not going to pay much attention to that because those who are obese, they will have visceral obesity as well. And we as a pediatric endocrinologist, and I was in a practice in the academic center for more than 45 years. In my earlier career, we hardly ever saw type 2 diabetes in children. Now, from the early 20s, I would say the later part of 1900 and early 20s, as the obesity started going up, we started seeing that type 2 diabetes in adolescent. And they present with hyperosmolar hyperglycemic crisis, and it itself is a different topic, but the risk of the obesity and type 2 diabetes is parallel. There is no question about that. It is the obesity which bring about type 2 diabetes in adolescent. Not to talk about essential hypertension, hyperlipidemia, and the young girls, adolescent girls, they are at high risk of developing polycystic ovarian syndrome as well. So the morbidity is also very significant as a result of obesity. So we developed a protocol or a suggestion to the primary care physician, pediatrician, which may not be exactly what the other people like to do. If the BMI is over 95th percentile, we carry on in-depth medical assessment and the treatment plan, and we'll discuss about the treatment plan. And we plot BMI in every visit, height, weight per meter using meter square, and there is a graph. Anywhere there is a graph that you can use to plot the body mass index. If body mass index between 85th to 95th percentile, the risk is very much there, and unless something is done, they are going to go in significantly going to go on wrong direction. We start diet, exercise, and a good follow-up program. Out of sight, out of mind. The follow-up program, and indeed a If they do not show up in our follow-up clinic, our nurses call them and ask them what happened, why they did not show up. It's not like they didn't show up, but we made an effort to bring them in the clinic. However, the BMI is less than 85th, slightly going, we discuss with the parents in every visit that the obesity is a real big problem and it really does not take much for a child to develop obese until the parents are careful. And nobody is immune. If it's Hispanic, African American, Asian, black, white, it really doesn't matter. Everybody is at risk of developing type 2 diabetes, and that should be discussed in every visit, so that it is actually the pediatrician should be discussing this as they do the follow-up clinic, as there is and the follow-up visit, immunization and all those things, and it is a good idea to discuss about obesity. Now everything is electronic chart, but it is there. But here is that, see the 50th percentile, and if you go up there, and the more higher you go, more danger we are going to face. When you do the medical assessment, the few questions that need to be asked specifically, in general, history, but these are the questions I think is very important for pediatrician or family care practitioner, family practitioner to ask this. Good medical history. Is there a history of type 2 diabetes in the family, early heart disease, and history of hyperlipidemia in the family? Severe headache, blurring of the vision, and severe headache, blurring of the vision, this could be suggestion of a condition where there is increased intracranial pressure, and this is associated with obesity. We'll discuss this one a little bit more. Snoring during the sleeping, and that will be a suggestion that there may be breath holding, or they may be having a problem at night, and sleep apnea as well. Hip and knee pain, chest pain and exertion, and difficulty in breathing during the exertion or passing out. I have arranged slides as a way, so we have those slides and it will be easy to follow them. Now in the medical assessment, the dietary history, this has been put by our nutritionist, and I think this is a good outline. Ask about the intake of liquid calories. What we found, like others, is the liquid calories like fruit juice, 7-Up, Coke, soda, and sweetened any another kind of beverage, and they are all is the hidden source of calorie, and some parents don't pay much attention and they think orange juice is good, apple juice is good, juice is always good food, but it's not. There is a lots of hidden carbohydrate loaded calorie right there. Now we also do the 24-hour diet recall, and actually we tell them to bring a 1 week's worth of food that patient has been or the kids has been eating. That could be breakfast, lunch, supper, and in between. And we tell them to be very honest and don't fudge the data, and very honest, and then only then if they are honest, we can help them. Not only that, it is a good idea to discuss with the family their eating habit and how often they are going to the fast food stores. Fast food where like a McDonald's, Burger King, and so forth. There are many. And how often they eat out there. And that will give you some idea the family's eating habit. Well, this is also I took from a obesity journal. And look at this. These are all very delicious food as far as the kids are concerned. But look at that, they are loaded with calorie and sugar. But this is what is snack. Either they're getting from here and the chocolate bar and so forth. And they don't have to eat that much. And there is a plenty of calorie here. So what they are eating in between meal or as a snack is also very important. And then I also got the same picture, diagram from the same magazine. Isn't that really good? How nice, big steak burger, big hamburger, and with Coke or soft drink and potato and the potato chips. And this is the common food habit in many families, and therefore I ask you, is that a good food habit? It looks delicious, but this is how people do not realize that how much calorie they are consuming in every meal. The other assessment that our exercise physiologist like to ask the family, and I put them here, how much activity and play they do every day. What the child do after school? What does the family do on the weekend? And how much TV they have been watching, and especially the children are watching in the weekdays versus weekend. And some people believe that the weekend, there is data clearly shows the weekend they watch more TV than the weekdays, but still how much? Okay. Does the child have TV in his or her bedroom? And that is a disaster. The parents go to the bed and they think that child has gone to bed, keeping the volume low. They may be watching TV for a long time, and as you know also that if they don't sleep well at night, they are also at risk of developing obesity. Activities is very important. The children should be active. This one looks a little bit risky to me, but activities is more important. Now, coming to the family history, those are the risk factors, especially anybody in the family before the age of 55, if they have a history of diabetes, obesity, hypertension, heart attack, stroke, and hyperlipidemia or dyslipidemia. So these are very big risk factor. And if somebody in the family has been diagnosed, the first degree of relative especially, is diagnosed with this any of this condition, this is a very high risk situation for that child. So medical assessment, and everybody has their own way, but in the physical examination I'm quickly going through that. You see the height, weight, plot it on the growth chart, then plot the body mass index, blood pressure, and then normally average we take about 3 times, because when they come to the clinic and we found out that their systolic blood pressure, specifically systolic blood pressure, is usually high, but once they settle down, it looks much more reasonable. Hip circumference, waist circumference measurement is a good idea, and keep that one in your record. A good thyroid examination, cardiac examination, making sure they don't have any underlying murmur and thyromegaly. Then you look for acanthosis nigricans. Those who have followed my lecture, I have discussed a case of type 2 diabetes and how to differentiate type 1 and type 2 in my earlier lecture. So I would like you to refer that, and there I have talked more about acanthosis nigricans. Fundus examination, if there is a headache, to make sure there is no papilledema, and excessive body hair. And as I said, the polycystic ovarian disease is one of the problem with adolescent, overweight adolescent with obesity. So androgen axis comes with that, and so excessive body hair formation in the area where it should not be, called hirsutism, and that should be also looked carefully. Enlarged tonsil and adenoid is another condition where they might be snoring at night, and hypoxia also might induce the obesity. That's what enlarged tonsil and adenoid should be evaluated, and in general as a good physical examination. And here is that I have much better picture in my uh, discussion of a type 2 diabetes case, but here this is a Caucasian, look like, but still this is acanthosis nigricans. Around the nape of the neck, it could be in the axilla and the bend of the elbow and all other places it could be. And this patient has a BMI of 52 kg. And then sometimes there is a cystic lesion, acanthosis nigricans, the skin tag, and it is almost like a skin tag or a cystic lesion, but mostly skin tag. So what are the complications? Acutely, what complication that one could see? Obstructive sleep apnea is a big one. They also develop pseudotumor cerebri, and that's the one give headache, blurring of the vision, and if you do a spinal tap, there is increased CSF pressure, but they have no other organic lesion, pseudotumor cerebri. And everybody knows the slip capital femoral epiphysis or skip is a big problem, especially around the age of 12, 13, 14, and so forth. So, basic evaluation should consist of a blood count, a metabolic profile including kidney function, liver function, fasting blood glucose with insulin level. A lipid profile is definitely a good idea, and thyroid function test. And we will talk a little bit about thyroid function test in the next slides or so. From our clinic, for over the period of 5 years, we have done this study published in JAMA in 2007. The reason we did the study, two things we saw. In endocrine clinic, we started getting, or we had referral of lots of overweight children with mild elevation of TSIs. However, they have normal T4, T3, and some of them have been taking thyroid hormone replacement, and the parents have been told the reason your child is overweight because of thyroid dysfunction. And with that thing in the mind, and since we had such a big data, we published the largest series of children more than 300 with control and obese. And we found that approximately 12% had elevated TSAs, which varies from 5 to 9.8 MIU per ml. Normal is up to 5, 1.5 to 5. And we found the TSA's level above 7 is associated with 14% positive thyroid antibodies, thyroid peroxidase antibody and antithyroglobulin antibody. So they have some autoimmune. And since then, there are many studies done in this country, and their data is very identical to what we found. And this article was so groundbreaking that it has been mentioned more than 90 times in the different journal, and they're used by the different people. So mild elevation of TSH is commonly seen about 12% of the cases, and the reason for that has been postulated, and those who are more interested, I will refer to the publication we had at 2007. The other known complication of obesity obviously is hyperinsulinism and glucose intolerance, type 2 diabetes, dyslipidemia, we discussed already, and hypertension, systolic mostly, but there is the diastolic and systolic, both of them are equally involved. Now there is a condition called metabolic syndrome, whether you believe in that metabolic syndrome or not, but this is what it is. Three or more of these following risk factor. I'm not going to get too much into that because some people do not agree. So it is the elevated blood pressure above 90th percentile, triglyceride level more than 90, and HDL level less than 40 per DL, waist circumference more than 90th percentile for the age, and fasting insulin is above 15 MIU per ml, and the fasting blood glucose is 100 milligram per ml, are there are very risk of developing type 2 diabetes. I found this is a very good diagram, and this diagram said it all. I don't have to explain too much. And this is cardiometabolic risk or global diabetic and CVD risk. Here is the age, race and sex of the family history, hypercoagulation and inflammation, hypertension, smoking. These are all risk factors. Down below and up here you can see the increased HDL, apoB decreased HDL, and increased triglyceride, and this is abnormal lipid metabolism that make another big problem for risk. And then the exogenous is the overweight or the obesity, insulin resistant, the high lipid, high BP, high glucose with obesity. And this is a beautiful diagram showing that who are at risk of developing this CVD, cardiometabolic risk. So what can we do in terms of intervention? So I think that as a pediatrician, we all advise parents and know that breastfeeding is the best way to go. And the data is very clear. If somebody breastfeeding the baby for a year versus bottle-fed baby, the breastfed baby is going to have the better weight and skinny than the bottle-fed baby. height and weight should be plotted in every visit, and the well baby checkup is very important. And share, if any, concern about the weight with the family. Now here I have seen some of my pediatric colleagues, they voice the concern that telling the mom or grandparents their child is overweight always make the situation a little bit tense, because nobody like to hear that their child is overweight. But put it differently. Don't be shy, put it differently and show your concern. They may not like it right at that moment, but as you educate them, as you keep on telling them, and you tell them that, well, if I don't tell this information, or if I don't share with this information, I will be doing a significant injustice to you. I know baby looks good, so this is something that we can prevent. Earlier, the better. And so therefore, it is important, even at the cost of being a little bit not liked by the parent in the beginning, and discuss this one with the family. And in long run, they will like you. And that is the right thing to do. And we all believe the delayed introduction of solid food, fruit juice, cereal, and American Academy of Pediatrics says 6 months or so. I think that's a good recommendation. Dietary intervention, and this was again put by our nutritionist, and these slides are there, but I'm going to go through them quickly. Stop or reduce all sweetened beverages. Indeed, now study shows that even the diet, those who containing the artificial sweetener, they are not also very good. Based on the new food pyramid, encourage the low glycemic index food. Limit white bread, potatoes, cookies, and cakes loaded with calorie and carbohydrate. Low-fat milk, usually not recommended, not really 0% or 1%, about 2% milk fat is good and provide enough fat that necessary. Fresh fruit and vegetable. The good food habit start early on. So the whole family, if they are eating healthy, the chances of success is high, better. I won't say high, is better. They should be drinking water, 6 to 8 glasses of water per day for hydration, and that should not be replaced by drinking juice or carbonated soda. Use olive oil, canola oil for cooking, and involve the dietitian from early on, and the dietitian will be able to channel them in the right way. And so early involvement of a dietitian, whenever you think that we are heading towards wrong direction, is always a great idea. And as American Academy of Pediatrics and the other people suggest that TV watching less than 2 hours a day is a good idea. Regular exercise, biking, walking, even treadmill at home if it is too cold outside. And some of the teenagers, they like exercise videos. They can dance with that video. Whatever it takes. Different stroke for different folks. Whatever it takes, that should be implemented. If financially feasible, they can join a gym. And in our clinic, we had a gym open from 8 a.m. to 6 p.m. No fees, they can come anytime and use the gym. So I think that was and that is still a good idea. And it always works if the whole family is involved with the diet as well as the exercise part. Family involvement is very important. So they see that everybody is doing like a monkey see, monkey do, as they like to say, that habit for the whole family will help the child significantly to achieve a better health. Again, a psychologist is very important. And many of these children and their family under psychiatric distress, and they know that their child is going in wrong direction, they cannot do anything, and they scold the bullies and calling name, and they could be very cruel, and all these things usually affecting their psyche. And therefore family involvement and understanding and desire to make changes, and that should always be encouraged. And don't put too many, one small amount of change at a time. And this is what the psychology is, small amount of change at a time. And then you continue reinforcement, and not limited to a few weeks, just continue reinforcement. And must be told in no certain terms. These kind of activities and this kind of food habit is going to be with them for the rest of their life. So if they know that, then they will accept it. So what is more important? This gain weight, look not appealing, or die early, or have a good, healthy life. Persistent lifestyle changes is important. So what can we do in terms of medicine? Nothing much that we can do, but we can do something. And there are some medicine, every time FDA is coming up with new recommendation and the age group and so forth. And this generic name is, they don't know, but this name is very familiar, Meridia. FDA has approved this for above 16 years of age, and it worked by inhibiting the reuptake of serotonin and norepinephrine in the hypothalamus. What does that do? It reduces the appetite. And you eat less, you lose weight. But side effect, there are some side effects beyond the discussion here. And then Chenical, which is orlistat, it's a pancreatic lipase inhibitor. Tremendous side effect. Troublesome gas, flatulence, diarrhea, and the leakage. When you have a friend like that who needs enemy, so what child is going to like that kind of side effect and taking this medication is probably more disabling. The metformin has been used successfully, especially if they have a type 2 diabetes or the early type 2 diabetes. Metformin increased the insulin sensitivity. It increased the glucose utilization in the liver. It increased the glucose utilization in the muscle without requiring that much insulin. And it also decreased the liver gluconeogenesis, and side effect is lactic acidosis. However, in children, it's not as big of a problem as seen by our adult colleague. Then we have got those Ozempic, Victoza, and these are the GLP-1 mimics or semaglutide, and this is given by injection, and this one has become so popular now that many of the adults they are using. The downside is that it has to be given by subcutaneous injection daily, and dose should be titrated, not covered by most of the insurance, and it's very costly. And when everything is uh, failed, and these are the places where we can use some of these pharmacotherapy. And surgery wise, as you know, that it for children the option of surgery was very limited. However, now it has found that the gastric bypass surgery, in the beginning it was 18 and above. Now it has found that it can be done once the is bone growth is complete. Bone epiphyseal plates are fused, and that could be 16. As you know, the obese children also have somewhat advanced bone age. So the gastric bypass surgery, gastric banding, and other medical surgery is in progress. Clearly, these children and the adolescent, they need to go through a tremendous amount of psychological evaluation, because if you do the surgery and if they do not abide by the things they are supposed to do, and they will be bad. And therefore, it's very important to select the patient, to select the patient carefully so that one does not have to keep on doing this surgery, repeat off and on and so forth. So other modified surgery is also in progress. As I said, gastric banding may be a good idea, but they will have to be after everything else has failed, and very good psychiatric counseling that whether this will be a good patient to undergo any of those surgical procedure. I got this picture, and I like to read it to you because I made this myself. Doctor told me that my blood pressure is dead high. My blood sugar and cholesterol are also borderline, and I need to eat salad and green vegetable. I need to go outside to be more active, but afraid of dog, hot and cold weather, and E. coli in the salad and vegetable. And when we were doing this thing, and there was an outbreak of E. coli, and so there is always excuse. Children will give excuse, that's their nature, but if the adult listen to them and follow the same route, then we are in trouble. Thank you very much for listening, and I like to share this information that we got, and I got very interested in these topics because this is something is preventable, and once we prevent it, then it will significantly reduce the health cost, and therefore anybody who is taking care of primary care physician or pediatrician in the first line of defense, the prevention of obesity is big health um, concern, and it should be done by every primary care physician. Thank you very much.